I've seen patients. So I'm going to start with a case. It was one of my patients from the early 1990s who was a 29-year-old woman who was sitting on the window ledge, not very high up, slipped off without much force and fractured her left hip. And so somebody thought this was odd and did a DEXA scan, and she in fact did have osteoporosis by DEXA scores at the spine and the hip. And so eventually she found her way to our clinic, where we did an exhaustive evaluation. She didn't really have any significant medical history. She was not exposed to any medications that caused bone loss. She had a slightly late menarche at age 15, but since then had regular periods with no amenorrhea. And she did have a family history of osteoporosis. On exam, there was really nothing very much of note. She was very slender, but she was certainly not malnourished in any way, and there weren't any stigmata of any type of bone disease. And in terms of an evaluation for secondary causes of osteoporosis, since virtually a lot of osteoporosis in young people is due to a secondary cause, really this was entirely negative, a very detailed evaluation, and bone turnover markers, et cetera, were in the mid premenopausal range. We did a tetracycline labeled transiliac crust bone biopsy on this patient, and that revealed thin porous cortices with disconnected trabeculae here. No evidence of any osteomalacia. There was no excess osteoid, but her bone formation rate was very low. And in terms of management, really, we just didn't have much to offer at that point, and she was maintained on an adequate calcium diet with vitamin D. She took an oral contraceptive anyway for birth control, and over the next few years, we followed her, and her bone density remained stable but low. She did not have new fractures, and in fact, she went through 2 pregnancies, after which she breastfed both children, which could be quite a skeletal stress, and she did not sustain new fractures during that period. And we evaluated her from time to time, and the evaluations were always negative for secondary causes. So I'm going to come back to this patient at various points in the talk. So what I'm going to do today is tell you pretty much about our studies in idiopathic osteoporosis in premenopausal women, the work that we did that was supported by NIAMS in the last half of the 2005 to 2010. And then I'm going to talk to you about some preliminary pilot data on osteoanabolic therapy, and then tell you a little bit about what our ongoing and future studies are. So just a few words about osteoporosis in premenopausal women. As you know, it's uncommon. The diagnosis is certainly a lot more stable and certain if there are low trauma fractures, because it's difficult to interpret low bone density alone in a young person. There's usually a secondary cause of bone loss, such as a disease or medication exposure, either that interfered with peak bone mass acquisition during adolescence or caused premature bone loss and fractures. And here's my ever-evolving slide of secondary causes of osteoporosis. There's a lot of these. And the goal really is to try and find one of these, because if one is present, you're much better off if it's addressable to address the underlying cause. But what I was really interested in was people like this patient, the idiopathic patient, where we really couldn't find. And it just was very puzzling to me why I would keep getting these referrals of these young people with fractures. So what is idiopathic osteoporosis? It's really an operational definition. It's generally considered to apply to premenopausal women and men under the age of 50 who are otherwise healthy, who have normal gonadal function with regular periods or no evidence of hypogonadism, and no secondary cause of bone loss after a detailed evaluation. In general, these patients are usually Caucasian. They usually present in their mid-30s with a 1 or more low trauma fractures that may cluster over a 5 to 10 year period. And it can be mild with 1 fracture, or it can be devastating with multiple vertebral compression fractures, like I've seen patients with 8 vertebral compression fractures with no trauma at all. So I think it can be quite a compelling thing to try and help these people. Now, idiopathic osteoporosis in men, in some studies that we actually worked on with Cliff Rosen years in the 1990s, tends to be associated with hypercalciuria with a low free estradiol and testosterone levels, and often is associated with a very low serum IGF-1 level, for whatever it's worth to measure circulating IGF-1. But bone biopsy studies mostly show low bone formation, and in general, serum IGF-1 and free estradiol are directly related to bone formation. So the lower the IGF-1, the lower the bone formation rate on a biopsy. And a minority of men with idiopathic osteoporosis seem to have high or normal bone turnover. So we became interested in premenopausal women and kind of hypothesized that we would have similar findings in premenopausal women as we had seen in our early studies with men. So we embarked upon an NIAMS-funded study of idiopathic osteoporosis, which was a cross-sectional case-control bone biopsy study. And we were able to recruit 40 adult women who had normal bone density and no history of fracture, 45 women who had anywhere from 1 to 12 low trauma adult fractures, and most had multiple fractures. And we were able also to recruit a smaller group of women who just had low bone density and didn't have any low trauma adult fractures, although some of them had had high trauma fractures and some had had childhood fractures. And these patients formed these study groups, and in general, most of the controls are always in green, the fracture and low BMD in blue and orange, respectively. And we performed bone transiliac biopsies after tetracycline labeling in all these women. They were very well matched in terms of age, and a low BMD group was a little smaller. They were different in weight. The controls were heavier and had higher BMI. So all of the analyses that we show you today are adjusted for BMI. I figured I was lucky to get 40 women to have a bone biopsy who were normal, so I couldn't really recruit them to be of the same weight. I would have had even more trouble than we did. So anyway, just to sort of review some of the findings from that study, we didn't really find, even though there were differences in weight, we didn't find much difference in whole body or trunk fat by DEXA or caloric intake by food diaries. There was really no difference in reproductive history. The typical things we measure: estradiol levels in the follicular phase, vitamin D metabolites, serum and urine calcium, and most bone turnover markers. We did see a few differences in serum PTH. The fracture and low BMD patients actually had higher, although completely normal, PTH levels than the control group, and the TRAP5B, an osteoclast marker, was higher in the two affected groups. And there were direct associations between PTH and all of the bone turnover markers. But really, that was the only biochemical thing that we observed that was different. Obviously, we always say that young people shouldn't have PTHs that are close to the upper end of normal, and we recapitulated that. We found that none of our control patients in an assay that was normal 10 to 65 had a PTH really much above 40, and it's actually a substantial proportion of the IOP patients did. So it just goes to show you can't really accept as normal the normal range according to this age group. As I mentioned, there were not very many differences in those things that I just reiterated, but the patients did seem to have a little bit more SSRI use, which is kind of interesting when you think about the role of serotonin in bone and the role of SSRIs, and are they associated with fractures and low bone mass. But we just presented last year at ASBMR the bone formation rate biopsy data on the patients on SSRIs and those who weren't on SSRIs, and we found no difference at the tissue level in bone formation rate. Now back to the IGF-1 issue in men. As I said, we had hypothesized that women would IOP would also have low IGF-1, and we didn't really find that. We found absolutely no difference in serum IGF-1 between the controls and either of the affected groups, and we didn't find any association with age-adjusted bone turnover markers and no association with bone density. Now, the bone mass and microstructure area of our study, obviously DEXA was lower in all the affected groups than the controls. We also looked, because there is an issue about, in the smaller skeleton, how accurate is DEXA in terms of assessing volumetric bone density. So we did look at central QCT of the spine and hip, and looked at trabecular volumetric bone density at the spine and trabecular and cortical volumetric bone density and cortical thickness at the hip. And just to summarize those data, this is compared percent lower than controls of the two groups. And at the lumbar spine, both integral and trabecular bone density and also the proximal femur and femoral neck were significantly lower in both groups, both the low density group and the fracture group. And also cortical area, thickness, and stiffness were lower in both groups. And there wasn't really any difference between the fracture and the low BMD group. They both had poor bone quality there. And we also used our central QCT results from the control to sort of calculate a poor man's Z-score for the subjects. And we found that at the spine, 18 of 19 subjects with a Z-score below -2 by DEXA also had central QCT Z-scores below -2. So DEXA actually, at least in our group, turned out to be a pretty good indicator of low volumetric BMD. And the positive predictive value of a DEXA scan below -2 for a central QCT scan below -2 was 95% at the spine and also very good at the hip. We looked at, used the extreme CT, high resolution PQCT to look at bone quality at the distal radius and tibia in the groups, and we found basically deficits in both cortical and trabecular bone in both groups, lower density, thickness, and porosity in cortical bone, and lower density trabecular number and higher separation and stiffness. And here are some representative HRPQCT scans of a control, a fracture patient where you can see the thin cortex and the central trabecular dropout, and a similar low BMD patient. We did micro CT of the trabecular bone cores from the transiliac crest biopsies, and found these are representative micro CT scans of a fracture patient and a low BMD patient. You can see the low BMD patient is pretty much as badly off as the fracture patient. And we also did, of course, by 2D histomorphometry, looked at cortical thickness, and you can see that the cortices are thinner and more porous in the affected patients. Looking at bone remodeling, we found, in contrast to the studies in men, a much more heterogeneous picture. And we didn't really find any group differences between the controls and the fracture or the low BMD group. So we grouped them according to whether bone turnover based on the bone formation rate was high, normal, or low. And in the shaded area is the normal range based on the control population. And we found that, some of the patients had quite high bone formation rate and others had very, very low. When we looked at those in the lowest tertile of the bone formation rate on the tetracycline labeled biopsies, we found that they actually had the worst microarchitectural characteristics. They had the lowest trabecular bone volume and stiffness, lowest osteoid width and wall width consistent with osteoblast dysfunction, but they had significantly higher IGF-1 in contrast to the men who the low bone formation men had lower IGF-1. And this kind of raised the question in our minds about whether these patients may have some form of IGF-1 resistance at the osteoblast level. It wasn't a lot higher, but it was significantly higher. And then we looked at women in the highest tertile, and we found that they had actually less severe deficits in bone volume, and they had slightly higher urine calcium and PTH levels and higher 1,25-dihydroxyvitamin D, perhaps consistent with a mild form of idiopathic hypercalciuria, since none of them had kidney stones and none had frank hypercalciuria. Okay. Looking at marrow fat, we looked at adipokines, and we didn't find any difference between the fracture and the low BMD group, and so we combined them, and we also then did not find any difference between serum leptin in the control or adiponectin in the control group and the IOP group. We measured marrow adipocytes using the methodology from Sandeep Kholsa's lab at the Mayo Clinic, and you can see these elliptical marrow adipocytes. And here we have a typical IOP patient, so you can see just eyeballing it that they have a lot of fat in their marrow. And we looked at adipocyte parameters expressed as percent difference from controls and found that whichever parameter we looked at, there were significant differences in adipocyte size, number, density, and volume per marrow volume in the groups. And they remain significant after we controlled for age, for BMI, and also for bone volume fraction by micro-CT, because you could say, well, they have less bone, maybe they have more fat because of that. But even when we controlled with that, we still saw differences. In the controls, we saw what we would expect in terms of association between marrow fat. We found that it got higher when they got older. There was no relationship between BMI and BMD. There was an inverse association between marrow fat and bone volume fraction and stiffness, an inverse association between marrow fat and bone formation rate, and an inverse association with bone turnover markers. But we didn't see really anything we expected in the IOP group. So just to sum up, in controls, marrow fat was lower, and what was there was directly associated with age and inversely associated with bone volume fraction, bone formation rate, and bone microstructure. And in IOP patients, we didn't see any relationships between these parameters. So we don't really know whether the relationship between fat and bone is fundamentally abnormal in IOP. Does the excess marrow fat, we had thought it might arise from a switch from osteoblast to adipocyte cell lines, but that didn't seem to be the case because the bone formation rate wasn't related. So we don't really know if this is just an observation or whether there's any involvement in the pathogenesis. Just looking, we also looked at, that didn't really come through, but this is a bone biopsy with a tetracycline label, and we looked at bone matrix composition right in the middle between the two tetracycline labels, so freshly laid down osteoid. And at these active bone forming surfaces, when the osteoid has just been laid down within the past few weeks, we found less mineral per volume of matrix, which would cause reduced stiffness. We saw evidence of more proteoglycan concentration, which could affect the local availability of free calcium or phosphate ions. We found more pyridinoline than divalent collagen crosslinks, which suggests that there could be accelerated collagen maturation even in this fairly recently laid down osteoid. And we found these differences were independent of bone turnover, and as you could see, happened right after the osteoid was synthesized, and could again reflect some form of osteoblast dysfunction. So just to summarize, so far we found consistent deficits in volumetric bone density, microarchitecture, and stiffness no matter where we looked, at the spine, the hip, the distal radius, the tibia, and the iliac crest. We found heterogeneous turnover, which could provide clues to varying pathogenesis. And we found higher marrow fat independent of bone volume and abnormal bone matrix. I don't know how this all fits together, but I'm open to hearing any ideas at the end. So in our conclusion, even though bone biopsy is sort of a radical step to take, and we don't really often recommend it, it can provide some clues to the pathogenesis of IOP, both in the broader sense and in the individual patients. And we also found that even though the low BMD patients hadn't had really major low trauma fractures, they were just as severely affected as controls. And whether this is selection bias, whether it's part of a continuum, or the fractures are just due to happenstance and bad luck versus anything else, we don't know at this point. So we then turn to thinking about what one might want to do about this. And just not to say that I am in favor of treating premenopausal osteoporosis, because I think it's a big decision. We know sort of how to treat postmenopausal osteoporosis, and then we know when and how to initiate therapy. Obviously, if a person has osteoporosis by DEXA, if they have low trauma fractures, or in some cases, if they have an elevated 10-year probability of fracture, we can say, okay, this person should be treated, and there's lots of clinical trial data to guide us here. But there aren't any clear intervention thresholds for premenopausal women, and it's a much more fraught decision as to whether one would treat it. That being said, if one felt one had to treat it, it would be nice to have some data to base your decision on. So in terms of, so my philosophy would be that obviously we want to recommend conservative therapy with calcium and D and exercise and no smoking and drinking and bad things for bones. But to embark on pharmacologic therapy is rarely justified unless there are major fractures, unless you're following people over time and they have low bone mass that is getting worse, or they have extremely low BMD, and that's a judgment call. I would say maybe -3 or below. So we embarked on an open label study that was supported by Eli Lilly in an investigator-initiated protocol. And we took 21 of the women from our original cohorts, cross-sectional study. They were about 39 years old, and we treated them with teriparatide for 20 micrograms daily for 2 years and did bone density every 6 months. Transiliac crest biopsies were done at baseline and at 18 months, and we also did extreme CT scans at baseline and 18 months. And we saw nice increases at the lumbar spine, of almost 11% overall, and also very substantial increases at the total hip and femoral neck, and not much change at the radius. And this is our patient who participated in our study and then also in our intervention study. And you can see this is where she started teriparatide, and she T-score went up from -2.6 to -1.4, so she had a relatively good outcome. We also, here's just a summary slide looking at what we observed in bone structural changes on the biopsies. Significant, almost 40% increases in bone volume fraction, trabecular number, a 20% increase in cortical thickness overall, a very big increase in trabecular stiffness by finite element analysis, but also an increase in cortical porosity. Here we have our patient's bone biopsies. Here was her baseline biopsy, and here was her 18-month, with the caveat that these were done on opposite iliac crests, and sometimes it's hard to be sure that you're exactly in the same place as you were on the other biopsy, but it did look better. We also have just here a summary of the HRPQ-CT data, looking at the trabecular structure, trabecular plates, which are shown here in the green, and the rods in the red, also cortical porosity here, and whole bone stiffness. And we found an improvement in trabecular structure, not surprisingly, more prominent in the trabecular plates, although this may just be because the trabecular plates are basically easier to detect anyway, because the rods could be very thin. We found also an increase in endosteal formation and periosteal resorption on the cortical, an increase in cortical porosity, although only at the radius, and an increase in cortical thickness. And when we looked at stiffness and failure load, they were both significantly increased at the radius and tibia. So we have evidence by DEXA, by a bone biopsy, and now by peripheral measurement of high-resolution peripheral measurements that the treatment appears to be effective, at least in looking at these surrogate markers, although clearly we're never going to have enough people to look at a fracture study. We did notice that there was quite a bit of variability in the responsiveness to teriparatide, which we also see in the postmenopausal population. And we really had almost 20% of the women did not really have any response by 12 months. And we were hoping when we saw the 18-month data, well, maybe it's just delayed, but it didn't really seem to continue to go up. They also had no increase at the hip. And what we found was that the people who were non-responders, who are shown in the purple, actually had a markedly lower bone formation rate, which is not so surprising, although sad, because it would be nice to have a way to treat these people with low bone formation rate. We see this also in postmenopausal women, that people with low bone turnover often respond less robustly to teriparatide. And we found also that the bone density response, in addition to being lower in the people with low bone formation rate, also the bone density response correlated directly with baseline bone turnover. And then back to the IGF-1 story, the non-responders with the low bone formation rate had higher serum IGF-1 than the responders. And there was an inverse, weak, but inverse relationship between percent change in bone density from baseline and serum IGF-1 at baseline. So the people who had very low, people who had low IGF-1 had less of an increase in bone density. So maybe more evidence of IGF-1 resistance. We've been more recently looking at these circulating osteoblast progenitor cells that have been found to reflect bone formation rate in various studies. We isolated them from PBMCs by flow cytometry. These cells were RUNX2 positive and OCM positive. And we found in other studies that they correlate directly with bone formation rate on transiliac crest biopsies. We also generated, this is work with Stavroula Castani, antibodies against the COP cell surface IGF-1 receptor. And we did measured mean channel fluorescence on flow cytometry, measuring the density of the IGF-1 receptor expression on these COP cells. And we looked at their relationship to bone formation rate on biopsies and their response to teriparatide in some of the women who had been in the pilot study. First, we found that we had 25 women who had these COP cells and IGF-1 receptor density data who had had bone biopsies after tetracycline labeling, and we grouped them by tertiles of bone formation rate into a low group, a middle group, and a high group, and these are the mean BFRs in each of these groups. And we looked at the COP cells percent of PBMCs in the low group and found out that they seem to track with bone formation rate. So the lower the bone formation rate, the lower the percentage of COP cells in the PBMCs. We also found that the IGF-1 receptor expression on the COP cells was lower in the middle and the low turnover group than in the high turnover group. And the serum IGF-1 was higher in the low turnover group than the other two groups combined, although there wasn't as nice a relationship as in the other two panels. We had 11 women from our pilot study who were treated with teriparatide, and they all had, and we had COP cells saved at 3 months and 18 months in baseline. And we saw a marked increase in COP cells after PTH administration and an increase in the IGF-1 receptor, a 234% increase in COP cells, and about 140% increase in the IGF-1 receptor density. And this increase in the IGF-1 receptor density predicted the 6-month increase in lumbar spine and bone density quite nicely with an R of 0.7. It was not as predictive of the 12-month as of the 6-month. And here's a typical responder. The IGF-1 expression measured by MFI in a responder, the height and the width of the curve. The height goes up, and the curve is shifted to the right in this patient, matched closely by age and pretty much by BMI, and to the non-responder. And the serum IGF-1 in the responder is 95, and the one in the non-responder is 252, so quite a bit of difference. So again, it's just part of this thing that just keeps coming back that we're very interested in looking at. So what are we doing now? Well, we're right now waiting for the results of whole exome sequencing of all the phenotyped cohort of women with IOP that have been part of our studies, and that's being done in David Goldstein's lab. So we're hopeful that that may shed some light and perhaps reveal some information about possible genetic things that we may not know about right now. So we are also completing, we've just finished, well, we've finished enrollment last year to an R01 funded by the FDA, phase 2 study for teriparatide for IOP and premenopausal women, and we've enrolled 41 women. It's a randomized placebo-controlled single switchover trial of teriparatide, and the primary outcome is bone density, and then secondary at the spine. Secondary outcomes are bone density at other sites, bone turnover markers, serum IGF-1, COP cells, and the expression of IGF-1 receptor on those COP cells. And also we're doing a quadruple labeled tetracycline biopsy at 3 months. So we label the patient, we give them tetracycline with 1 tetracycline before they start the teriparatide, and then another tetracycline 2.5 months later, and then we get a 3-month biopsy. So in a single biopsy, we can measure bone formation at the tissue level before and in response to teriparatide. And we're very hopeful that this will help us look back at the non-response issue and really have data looking at whether that in fact turns out to be true in this group. So let me see. So this is more about the study design. And then what we do at 6 months, those who are randomized, so they're randomized placebo in an uneven design. And at 6 months, those who get placebo are then switched to teriparatide, and everybody gets teriparatide for 2 years. And here we have, these are not coming out, but if you can see, this is the label before teriparatide here, and then I'm sorry, these also, in addition to no color, they're in the wrong place. So this is before teriparatide, and you can see that the extent of the label after teriparatide is much greater. This patient who was biopsied after being on teriparatide. So far we have data looking at a bone formation rate in the 3 envelopes, in the placebo group and in the teriparatide group. Baseline is in green, 3 months is in blue, and you can see there's a very nice increase in the cancellous bone formation rate, and also seen in endocortical bone and in intracortical bone. And the absolute change in the cancellous bone formation rate on teriparatide has correlated directly with baseline bone formation rate. The higher it is, the more change there is, and also with the 3-month absolute change in C-telopeptide and P1NP. So our study is really in December, I think, or January, the last patient will have finished the 12 months. And so we'll be starting to use some of these data to look at the predictability and some of our preliminary observations in our pilot study. So in classic endocrinology, when you have a clinical feature of hormone resistance, it kind of can resemble a hormone deficiency syndrome. So we think that if women with IOP have and low bone formation and high serum IGF-1, if they have IGF-1 resistance at the osteoblast level, they could manifest the phenotype of patients with low IGF-1 due to adult pituitary growth hormone deficiency, such as low bone density, low lean body mass, increased visceral adiposity and insulin resistance, increased serum LDL and cardiovascular risk markers. So my colleague, Adi Cohen, who's really been central to all of these studies, and we've worked close together for years, has just completed an R03 that enabled us to collect data to look at all of these outcomes in our FDA-funded R01 study. And so her hypotheses and aims are that women with IOP with low and high bone formation will differ with regard to basal and stimulated serum, IGF-1 and IGF-1 binding proteins. And so we plan to compare the subjects with high and low bone formation with respect to these parameters. And that premenopausal women with IOP and low bone formation may have evidence of IGF-1 resistance in non-skeletal tissues. And so we will be comparing the subjects with low and high bone formation rate for evidence of fat differences in fat distribution. We'll be looking by DEXA, by CT to measure SAT and VAT, and by MRI, MRS to look at marrow fat, and serum adiponectin and leptin, obviously, and CV risk markers. And then we'll also be looking to see whether this predicts responsiveness to teriparatide in women with IOP according to our new study. So what about after teriparatide? So we know that when you treat postmenopausal women and men, bone density declines when you stop the teriparatide if it isn't followed by anti-resorptive therapy. And we had hoped that menstruating women with lots of estrogen aboard this would be mitigated. And in fact, in postmenopausal women on estrogen, it does appear to be mitigated. But what we found was when we were able to get 15 of our women from the pilot study back to be rescanned at 2 years, we found that indeed there was some loss at the spine, but perhaps not as much as one might have anticipated if you were postmenopausal women. And the bone density at the hip had appeared to be stable 2 years out. We also found that those who lost significant bone mass at the spine actually were significantly older, in their mid to late 40s, as opposed to their mid to late 30s. So it may be that that subgroup with waning estrogen production in the 40s may not have enough estrogen to counter that. So do we need to prescribe anti-resorptive therapy in premenopausal women? Well, we probably do. And then the question arises, which anti-resorptive should be used? And I think that depends on the clinical situation. You know, if somebody's 45 and not having children, maybe bisphosphonates might be a good idea. Future choices could involve more anabolic therapy. Maybe somebody else might need estrogen. So I think that is sort of a case-by-case analysis with the patient. But what we were able to do was obtain some funding, initial funding from Amgen based on the results of your data switch studies, actually, we were very interested in looking to see what would happen with denosumab after teriparatide. And so we are now funded by the, again, with another R01 by the Orphan Diseases Branch. And the subjects in that are women who've completed the R01 on teriparatide and now want to enroll in this denosumab phase of the study. So we've enrolled 26 so far. And anecdotally, this is an open label study. We don't really have the power to do a clinical trial, but we're observing further bone density increases that are substantial on denosumab. However, what about after denosumab? So we all know that bone density goes down fairly rapidly after denosumab is stopped. And then, of course, recently there have been reports of multiple vertebral fractures after discontinuing denosumab, particularly in women who have vertebral fractures before or fracture during denosumab therapy. So that has prompted us to try to be more, and actually your paper about how, when you refer to people back to their doctor to get put on therapy after denosumab, actually substantially fewer than one would have hoped got put on any resorptive therapy. So we are now working with Amgen to design a study comparing alendronate and zoledronic acid in premenopausal women who want to do that after they've completed the denosumab phase of the study. So that's where we're going in the future. And I would like to thank you all for your attention. I thank our funders and also all my team, especially Adi, who really has been central to all of these studies, and also our patients and research participants and all the people who've worked with us at Columbia and other institutions. Thank you.
We have time for a question or a comment or two from people. John?
You probably haven't got this data yet, but you mentioned about the IGF-1, high IGF-1 in the response. In the patient you've already studied, can you look back at it and decide if that had an influence on whether they responded or not?
We can't do that yet, but we should be able to do that after the last patient has finished the blinded portion of the study. So that we should be looking at those data in early 2018. The last patient will be out.
I love the idea of looking at other possible ways these patients are resistant to IGF-1. I'm guessing that they aren't shorter than controls. I mean, the question of when the IGF-1 resistance,
right,
if that's what it is, started, if it was before or during puberty, they might well be shorter.
Yes.
And they are a little shorter.
They were in our cross-sectional study. They were a little shorter. The patients were, yeah, but not necessarily. We didn't really see, because the numbers were small, we couldn't really see a major difference between the people with the lower IGF-1 or the high IGF-1.
Good.
But we'll now have another, we had 64 patients, now we have another 40, so we're going to have, over 100 patients. So hopefully we'll be able to put all the data together and be able to, find some answers, and also be most interested in anything you may have any insights you might have, because sometimes I feel like I haven't really solved anything. I've just raised a lot of really difficult questions to answer. So
it's an important function, though. One last question.
I may have missed it. I guess these who are not, this is not hereditary, right?
Well, there is a higher prevalence of having a positive family history of osteoporosis in the people who are in our studies, and we are currently awaiting the results of whole exome sequencing to see whether there are any known or perhaps unknown mutations in these patients. They could, I suppose, have a mild form of OI, but there was nothing else to suggest that. We don't know the answer to that question yet. But if we would like to actually start kind of a family study, but we don't really have the funding to be able to do that right now. So perhaps we can interest in that. Well, she did not fracture. Her bone density went down while she breastfed and came back afterwards to its low level. So thank goodness she didn't fracture. I mean, with the problem of pregnancy and lactation-associated osteoporosis, we really often don't know whether the patient had a pre-existing condition and then the stress of late pregnancy and lactation on the skeleton precipitated fractures, or whether it's a syndrome in and of itself, or whether it's a little of both, depending on the situation. But she managed to come through without having multiple vertebral fractures, which are typical of people with pregnancy and lactation-associated osteoporosis. So that was good.
Thank you very much, Elizabeth. That was a wonderful presentation. Before I introduce